Welcome to The Explainer. I'm Dr. Chem, and I want you to picture something with me for a second. Imagine red blood cells flowing through your vessels in ultra-slow motion. They're carrying the very essence of life, and hovering right above them are these glowing microscopic labels, A, B, AB, and O. Today we're exploring the incredibly high-stakes science of immunohematology. You know, in a modern medical laboratory, surrounded by humming centrifuges, high-res microscopes, and perfectly sterile glass slides, decisions are made at the microscopic level that have massive, life-altering consequences. We're going to trace an amazing arc today, starting all the way back with Carl Landsteiner's foundational discoveries of blood groups over a century ago, right up to the cutting-edge molecular genetics that ensure blood transfusions are safe today.
So let's just dive right into it with the most critical question. What actually happens if incompatible blood mixes in a patient's veins? Well, it triggers what we call a violent immune-mediated hemolytic reaction. Basically, the body's immune system flags those transfused cells as dangerous invaders and just launches a massive, systemic attack to destroy them. Understanding this really severe biological rejection highlights exactly why absolute precision at the lab bench isn't just a best practice, it is literally a matter of life and death.
We've got a seriously packed roadmap for today's explainer. We'll be starting with the biological baselines, the ABO and Rh systems. Then we'll walk through how we actually test for those at the lab bench, and finally, we'll wrap up by looking at modern DNA-based typing and what the future holds for patient safety. All right, let's get into the fundamentals. We have to start with the actual biological building blocks that make up our unique blood profiles. Let's zoom way in on the red blood cell itself. Think of this like a microscopic 3D animation of a lock-and-key relationship. Type A red blood cells actually have these tiny A antigens physically protruding from their surface. But here's the crucial part. Floating right next to those cells in the plasma are anti-B antibodies. Your body is perfectly designed to attack what it doesn't recognize. Type O, on the other hand, totally lacks those surface antigens, but it carries both anti-A and anti-B antibodies. It's this beautifully balanced, yet incredibly volatile biological system. And we can't forget the Rh factor. That's the D antigen that determines if you're positive or negative.
And that brings us to the absolute core mechanism of all this, agglutination. When an incompatible lock and key meet, say an anti-A antibody bumps into an A antigen, they instantly bind together. If you were looking at this through a laboratory microscope, you wouldn't see free-flowing cells anymore. You'd see them literally crashing into each other, forming these dense, solid clumps. This visible clumping is the biological reaction that historically drives all our serological lab testing.
Moving on to our next section, let's step up to the actual laboratory bench and see how we trigger this clumping mechanism in a highly controlled environment. Picture a lab technician, decked out in strict protective gear, working at a clean bench. They use a brilliant two-step verification standard. First, there's forward typing. This is where we drop precise amounts of commercial antisera, anti-A, anti-B, anti-D, directly onto the patient's blood to identify those surface antigens. Then we totally flip the script for reverse typing. The technician takes the patient's plasma and mixes it with known reagent cells to see what naturally occurring antibodies are hiding in there. And of course, careful mixing with totally separate applicator sticks is absolutely essential here to prevent cross-contamination. By running these two processes side by side, we create a built-in vital failsafe. An accurate ABO blood type is only officially confirmed when the forward and reverse results match perfectly. If the forward test says type A, but the reverse test is missing the expected anti-B antibodies, well, we've hit an ABO discrepancy. And in a medical lab, a discrepancy means a full stop. Nothing moves, no blood is issued, until that puzzle is completely solved. So with that theory laid out, let's talk about the physical testing methods and how they've evolved over time. Over the decades, the actual physical act of testing has gone through a huge evolution. You have the manual slide method, literally just mixing a drop of blood and antisera on a glass slide, which is mostly just for rapid emergency situations now. Then there's the test tube method, which uses centrifuges and careful washing. That's been the gold standard for years. But today, the modern laboratory has heavily shifted toward column agglutination, which you might know as the gel card method. And looking at the clinical data makes it totally clear why labs are making this shift. The gel card method is just dominant when it comes to efficiency. It cuts testing time down to about 30 minutes compared to the hour or more you'd need for complex tube tests. Plus, and this is a big one, it upgrades the interpretation. Instead of a tech subjectively eyeballing a shaken test tube to look for clumps, you get an objective result permanently trapped in a gel matrix that can be easily documented and reviewed. Now, despite those procedural differences, it's worth noting that both the tube and gel card methods boast a 100% sensitivity rate for specific parameters. That just goes to show that standard serology is still incredibly effective for your routine, straightforward blood transfusions. But as we all know, real-world medicine is rarely straightforward. The strength of that clumping, the agglutination, can range wildly. It could be a solid, unmistakable dark red chunk, or it could be a super faint, barely there smear that you can barely catch under the microscope. Relying purely on visual hemagglutination grading leaves room for ambiguity, and that introduces some really serious complexities for our lab technicians.
Which brings us to our next section. Let's raise the stakes a bit and look at what happens when standard visual serology tests just aren't quite enough to guarantee patient safety.
You see, the human blood system is vastly more complicated than just ABO and Rh positive or negative. There are actually over 40 recognized blood group systems. And beyond your naturally occurring ABO antibodies, if you're exposed to foreign blood, say from a previous transfusion, or even maternal-fetal blood mixing during pregnancy, your body can develop unexpected allo antibodies. Once that happens, finding a safe match for a future transfusion turns into a highly dangerous minefield.
There's a great point highlighted in the Annals of Blood about a massive limitation here. Accurate antigen typing is incredibly difficult when donor cells are already present. Think about it. If a patient just received a life-saving transfusion, their veins are now full of a mix of their own cells and the donor cells. If a tech uses a standard visual test, they might accidentally test the donor's surviving cells instead of the patient's, and a false reading there could literally lead to a deadly mismatch the very next time they need blood.
So, for highly complex cases, like sickle cell disease patients who need constant chronic transfusions, or when we're trying to differentiate between really subtle variations in the Rh factor, relying on visual clumping just hits a hard biological ceiling. Plus, sometimes commercial antisera don't even exist for the incredibly rare blood antigens out there. We desperately need a deeper level of analysis.
And that is exactly where the molecular revolution comes in. To solve these life-threatening complexities, immunohematology is moving away from the cellular level and going straight down to the DNA.
Molecular typing is a total game changer because it directly reads the patient's genetic code. It specifically searches for single nucleotide variations that dictate blood group antigens. And because we're extracting DNA from nucleated cells, the fact that there might be transfused donor red blood cells floating around is completely irrelevant. Warm autoantibodies, or a lack of rare commercial serums, they no longer block us from finding the absolute biological truth.
This kind of genetic precision builds a vastly safer medical landscape. By targeting specific blood group loci, laboratories can now predict phenotypes with absolutely incredible accuracy. This is actively revolutionizing prenatal care, allowing doctors to see if a fetus is at risk of hemolytic disease without any invasive procedures. It's also completely transforming how we manage sickle cell disease over the long term by letting us match highly specific, extremely rare genotypes.
Let's bring this all together in our final section and look at how this molecular methodology is reshaping patient safety and healthcare outcomes right now. I want you to consider the number 26,700. That represents the estimated doses of Rh immune globulin administered to pregnant women who didn't actually need it. Why did that happen? Because traditional serology just couldn't distinguish between a safe weak D variation and an at-risk partial D Rh variation. DNA testing solves this immediately. It saves critical medical resources and it spares thousands of patients from completely unnecessary treatments. If there's one crucial takeaway from today's explainer, it's this. Precision in the laboratory translates directly to survival in the hospital. As we make this transition from just observing cellular clumps in a test tube to actually mapping complex genetic codes, we aren't just making lab work more high-tech, we are completely eliminating the guesswork. We are directly preventing adverse hemolytic reactions, and we are saving lives.
I'm going to leave you with this final thought. As whole genome sequencing becomes faster, cheaper, and more integrated into routine clinical care, will adverse transfusion reactions just become a complete relic of medical history? Will we see a day where your entire genetic blood profile is just mapped at birth? Picture millions of uniquely typed cells flowing safely through the human body, perfectly matched every single time. It's an absolutely incredible future for immunohematology. I'm Dr. Chem. Thank you so much for joining me on The Explainer today.